Good evening. We are going to start the last cataract session. And we will have challenging cases to discuss. So we will start. Dr. Ahmed Musallam is not here. So we will start by Dr. Safwan Al-Bayati. And he will talk about new approach in hard cataract. We have 7 minutes and overall,
I will try because
we can have overall 10 minutes.
Yeah. Hopefully that it will continue and it's this way. Good afternoon, everybody. And we are ending this session, this meeting. Hopefully that we can be valuable here in this session. The new approach in hard cataract, and the session is a hard cataract, and we are passing a hard time, unfortunately, here. Now, I have 5 perils for a hard cataract. All of us facing a very difficult time with the hard cataract. The first peril, we know all that the problem started with a large cataract from the capsulotomy. I think that you can take the PC and connect it there. No, you need the connection?
Yeah, I will. Give me 1 minute.
Yeah. So that hard time started from the capsulotomy, and all know, and Dr. Salah and Dr. Ashraf, that from the capsulotomy, our story will start, especially in brown cataract or cataract nigra. In these 5 perils, I will show that a new approach to go through and solve each problems. So first of all of us, we know that in hard cataract, we need a large capsulorhexis. And we need to skip the hydrodissection in the beginning. Because one of the important problems that we are facing is the hydrodissection. So I skip it here in this approach. I'm not doing it as a second step. The third thing that we need to see that the problems coming from the very hard nucleus, center of the lens. So I'm tackling this hard center as a concavity. So I'm creating a tunnel, this tunnel about 2.5 to 3 millimeter in. The excavation in the center of the hard cataract. The third peril, division of this nuclear through the excavation. And the fourth peril is the hydrodissection. Through the division back, it will be very easy. And the fifth peril is divide each half into 3 pieces through a vertical chopper. Now this video is a real accelerated a little bit, but will show you all these steps. And the steps will appear in the bottom. Play, yeah, I'm playing. Now the capsulorhexis, you can see that I have digital marking, but I didn't use it because I need to use the largest as possible as I have, because most of those patients, they have a small pupil, but here I was not in need to enlarge more than that. I was on the margin under the pupil capsulorhexis. So I finished the capsulorhexis, and the second step is the pre-chop if they have, see, so I'm removing the pre-lens and I start here to excavate. The excavation, 70% of the lens. See, 70% in the center. Leaving the margin, definitely the lens is very hard, and you can see I'm reaching up, down. This is the cataract nigra almost. Then divide. This division, the vertical division, through and through. Now I'm doing the hydrodissection. The hydrodissection now, It's very safe. And then I will start my chop. Methyl cellulose, definitely, that we will be in need for it more frequently. Rotate, the nucleus will be rotated very easily. Make sure that it's divided in a full. And then I will start my chop. And the chop, I'm using Centurion, so I'm manipulating the foot pedal in a way that I can hold the nucleus in a good way. See, more methyl. Each step I'm putting methyl just to protect the endothelium. Three-piece. Make sure that I'm holding the nucleus. And now I'm to the second half. Three-piece. And then now I have 6 pieces, and I will go to the quadrant removal and easily, and you can see that the pressure that I'm using is only 30, because this is an active fluidics. And the vacuum, sometimes it can reach, it's a linear, from 250 to 600, but hardly that once or 2 times I reached the 500. See, these pieces was not separated, so I separated first, and then I will go to see to the suction. It's hardly to reach, sometimes reaching 500, and that's all. So let us go to the second case. This is the second case, and we can see the same, a large capsulorhexis. The excavation, sometimes they are asking me how you are sure that you are going to 70%. Well, with the time we can see that, because here, now this case was less hardness than the previous case, so you can see the red reflex, but in the Cataract nigra, hardly to see the red reflex. And you can see that the excavation is so deep in a way that I can see clearly that I can divide the nucleus. Now I divide it. Hydrodissection now. I have a cannula that have 2-side hydrodissection. That's what I am using here. So I'm just passing in the center of the nucleus and push the fluid onto the 2 sides. Now I'm dividing the 2/2 to 6. Here the bulk of the nucleus is gone by the excavation. The hard part of the nucleus is gone. The periphery will be whatever the hardness of the nucleus, it will be less hard than the center of the nucleus. And by this, I can save the capsule, because usually they have weak zonules, they have weak capsule. So here, the manipulation as a whole, it's less than when you are doing the classical divide and conquer or a classical chop. I think that's the end. Thank you very much. Any comment, any question?
Thank you, Dr. Safwan. I think we can discuss the hard cataract with the other talk. I will have a talk on hard cataract, so we can have questions, more time, and discuss different techniques. And now we will move on with Dr. Ashraf Armeya, who will speak about not only hard cataract, but subluxation, 2 different situations. So we are moving into another challenge. Of course, Dr. Safwan have shown one of the most difficult challenges, and we all face. So let's move on with Dr. Ashraf.
Just switch. Thank you, Dr. Yahya, for the invitation. And I was going to talk about hard cataract with zonulopathies, but I changed it to cataract with zonulopathies. So I don't have financial disclosure, and these are my companies. So I'm going to present 2 cases. One of them, both cases has a zonulopathy, but every case has a history and special character on the slit lamp that it gives you the clue that this case is not a regular case. This is very important. So this case is a female patient, 65 years old, history of drop of vision was gradually after trauma since 5 years. On examination, there is a weird shape, dense posterior subcapsular cataract, not the usual way of the cataract, with radial shaped cortical cataract was seen. This is the picture. So, this is so weird. You cannot find a cataract like this. There is a cataract here, and there is a track. So definitely, this is an abnormal cataract and related to the trauma. So you should expect that this is an abnormal site for the cataract. So this is what was in my mind before I start surgery, and I planned everything in the operating room. So, let's start. So I'm trying to, the paracentesis as normal, injecting viscocohesive OVD, opening the anterior chamber, and once, see, very important to look for this. This is a very important sign. You don't miss it. Once you start the rhexis and you press and you find these wrinkles, this is a weak zonules. And the wrinkles not all over the capsule, it is a localized at the area of abnormal cataract. So this quadrant has a weak zonules. Continue. So this is the first sign. Continuing the rhexis, very good, hydrodissection, and then during rotation, okay, this is what happened. During rotation, I found that there is a subluxation here and here. I'm going to continue. This is the second sign. During rotation, so this is a weak zonules. Don't say I can manage. This is very big mistake. So stop, put your capsular retractors at the sites of subluxation. Why? Because these capsular retractors will make a new zonules for you and very good zonules. You are going to see how we are going to continue the case, and the end you are going to find the rhexis is still central. So continuing, now the zonules protected by the capsular here. Continuing the cataract as usual. I use divide and conquer. This is my technique. And then chopping each piece like this. It's not a hard cataract. It's a grade 2 to 3. So usually in these cases, decrease the fluidity. Don't go for heavy or rapid phaco. And always maintain your pressure inside the anterior chamber. Take your time. This is the actual time for the cataract. I didn't speed it. So this is the actual time. I finish. Again, don't go out unless you inject OVD to maintain the pressure, because this is a very weak area. Maintaining the pressure before you go out. Take your time. This is not a rapid case. So also before you changing your bimanual, inject OVD. CTR mandatory in these cases. Don't leave the eye without a CTR. And I put a modified CTR Sione in case I found that the bag will not be central. But after I removing all the OVD behind, and I found that everything is fine and central. Why this happened? Because you know the history. You examine the patient properly on the slit lamp, you prepare all your tools before surgery, and then you continue the surgery. This is the first case. The second case, when you have a pseudo-exfoliation, which is the most common type of cataract that have a zonular weakness. So when you have a cataract, considering surgery should be evaluated for pseudophakia, surgeon should be aware of the possibility of polypupilly dilated. Complication can happen in any stage of cataract surgery. Caution should be taken during every stage of surgery and avoid any complication can happen, and surgeon should have the knowledge that this is a case of pseudoexfoliation. So, this case is severe pseudoexfoliation. This is not a regular pseudoexfoliation. It has a severe exfoliation on the anterior capsule, and when you see this mark on the anterior capsule, it means highly affected pseudoexfoliation. And the last papers in the last 3 years, they found that corneas with pseudoexfoliation have poor endothelial count, and they are prone to compensate easily. So you should protect your cornea in these cases. So we are going to start. The rhexis is very important because you need the rhexis either for secondary optic capture, put it in the sulcus, a lot of things. So take your time in your rhexis, staining mandatory, even if you see a red reflex, and large as you can, but not too much large, and continuous and central. I did hydrodissection, but during rotation, see, all the nucleus with the bag is moving. So don't say, I am an expert surgeon, I am going to take it without anything. This is a mistake that can happen to any one of us that he feels he's confident doing surgery. So maintaining your capsular bag in these cases with the capsular retractors is a safeguard for you. So I put my four capsular hooks, and then I'm continuing the surgery. You are going to see how the surgery, this is very hard cataract, and how the surgery will going to be okay. You are the same. I do divide and conquer also. Then I do shopping, 2, 3, 4 pieces. But in these cases, you should every time put a lot of OVD to protect your endothelium. Again, I finish the half of the nucleus, injecting visco adhesive or dispersive, and then continuing the third quadrant. I usually do high phaco, high vacuum with low parameters of the ultrasound, again protecting the endothelium, because these cases of severe exfoliation have a compensated endothelium count, not count the healthy of the cells. I am continuing. See, the bag is totally stable. I am doing a lot of maneuvers inside the eye, but the bag is highly stable with these capsular retractors. I'm doing a slow motion phaco, because in these cases, in hard cataract, the posterior capsule is like a trampoline. It can come easily in the tip of the phaco. I'm finishing. And you can find that the bag is perfect. Don't go out like I did, injecting OVD, removing the cortex, everything is fine. And then mandatory in these cases to put a CTR in pseudo-exfoliation when it's severe like this. And with these modified Shang capsular retractors, the CTR does not go entangle in the holes of the capsular retractors. And now you can find that the bag is still central, everything okay. I put a single piece inside the bag, and then removing the capsular hooks. So my home take message, I always preserve the bag. The best anatomical and physiological place of the posterior chamber IOL is inside the bag to give the best vision for the patient, so don't lose your bag capsule easily. To do this, you need good microscope, good depth of focus, high magnification, good instruments with a plenty of dispersive viscoelastic type, and good amount of patient. Thank you so much.
شكرا دكتور أشرف. هل في preference ما بين ال type of intraocular lens اللي you implant in a case of subluxation, whether you have capsule tension ring or not, a 3-piece versus 1-piece, overall diameter?
Yes, if there is a subluxation, and when I put a CTR, I found that the rexus is central and stable bag, I go for a single piece. If I found that the bag is not totally central, after the CTR, I go for 3-piece IOL in the sulcus. Then I do an optic capture. Instead, I putting a CTR, because CTR inside the bag is stretching the posterior capsule and stabilize the zonules. If I found that the bag is not stable, sometimes I put a 3-piece inside the bag, and then I make the optic outside the bag as a retro capture of the anterior capsule.
Okay, this is, I don't know if Dr. Safwan would agree or not. It's very important point, but also you can use the 3-piece lens, even if you have a capsule tension ring and the subluxation is a bit big. You don't want to implant the lens in the capsular bag. You can implant a 3-piece in the sulcus, so it will be stable over time. But for subluxated lenses in general, you have to identify one important thing. Is this a congenital subluxation or traumatic subluxation? Congenital subluxations and cases like pseudoexfoliation, these are usually progressive. So if you have a progressive subluxation, whatever you do, you might have the lens with the bag, as we see a lot now, dislocated in the vitreous. I don't know if you, Dr. Safwan, agree or not. If it is traumatic, usually if you fix it with a capsule tension ring or Ahmed segment or a Sayoni ring, usually it will stay where you leave it. So this is a point you should consider.
Yeah, I think that you are very right, Dr. Yahya. The issues is that when we are having the subluxation, in my practice, I'm doing the two-side. Because even in traumatic, you don't know the situation of the zonules of the other side. And you'll surprise after 1 month or 2 months that the lens is decentered, and when the side that you fix it on the right, on the nasal or temporal or whatever, the site of the subluxation.
You mean when you suture one side? You mean?
Yeah, I'm suturing for
two sides.
Two sides. So when I'm deciding to do it, I'm doing for two sides, because even in traumatic, you don't know the situation in the zonules. You don't know the nature of that's right. You are seeing something, but there is something hidden. So to be sure, and I do agree fully with you that the 3-piece will be more stable, but because I'm using a hydrophilic 4 eyelets, I can pass it. Even if I have any subluxation, I will return back and do the 4 flange, so it's easy for me to use the hydrophilic. Hydrophilic is very friendly to the uveal tissue, but hydrophobic, no. So if someone that is using single-piece hydrophobic, no, I'm suggesting to use a 3-piece lens in a way that putting it in the sulcus or capturing in retrograde or inside, because you might face a trouble after the implantation.
Okay, thank you. Would you like? Thank you, Dr. Ashraf.
Now your presentation, right? Dr. Yahya, just let us see what's his. Dr. Yahya, he will present the 2 nuclei concept for the rock hard cataract.
This needs. Yes, but just let him. Okay. One of the important things in our area, we see hard cataracts, as Dr. Safwan has shown, and in my opinion, that we should really have a system, understanding of how to deal with these cases reproducibly with good results without fearing these cases. So the hard cataract can be any one of these types. So you have to deal with each one with its specific challenges. But always you have to analyze what is you are worried about in such cases. And our main fears in such hard cataracts is that we can destroy the cornea and get corneal decompensation if we don't use the proper technique. Or we can open the posterior capsule, and then we are faced with a problem if a hard nucleus falls in the posterior segment, which is more difficult to remove. So these are the two main fears, and we should analyze and have a concept. The concept is not about removing the cataract. It is about removing it safely, because sometimes people think when they are doing, or you see juniors working with the hard or a regular cataract, you will always hear all the time. You're hearing ultrasound. So if you're using too much ultrasound in the wrong place, which is near the cornea, you will get problems. So you should have a strategy to convert a difficult case into a regular case. Every one of us is well trained to move into hard cataract, is well trained in the softer cataracts or immature cataracts. So you want to convert the difficult cataract into a cataract that you can really do. So what are the challenges? So you are analyzing the problem. One is the capsular axis. You need a good capsular axis. So you can overcome this because there is no visualization with capsular stain. Two, you have a thick nucleus, so you want to convert this into, and the hard nucleus, you want to convert it into a more amenable nucleus. So this is what I call the two nuclei concept, which is the main part of this talk. So the idea I have, the term I call it two nuclei concept. So it's a thick nucleus, so we consider it in your mind as two nuclei. So you want to get rid of the extra nucleus to deal with the remaining nucleus in the same way you are used. Because when you have a thick nucleus, if you use your ordering technique, you have a problem going deep. So you are not seeing deep enough. And if you're not seeing well, you are afraid, so you try to fracture, and this is what I think it's a wrong nomenclature, saying gummy nucleus. There is nothing called gummy nucleus. It is that you are not you did not go deep enough to crack the nucleus. Once you deal with this with a good view, then you can deal with the remaining part of the nucleus in a more or less a regular way in the capsular bag away from the cornea. It's exactly like I've shown in the previous slide, and there is a step which I call a hole drilling technique, which I published like 15 years ago. Hole drilling technique is an additional thing if you face a very, very, very hard nucleus. So you want to weaken this shell that you have. Like if you want to tear down and put down this wall, the easiest way is to make holes in it and then just push it, it will crack, it will fall. So this is just an introduction of what we should really, how to approach such cases. So how to create to remove the superficial part, which the upper part of the nucleus, I say like the upper 1/3, and you have the bevel down, and you shave and hover over the nucleus. You want to create a well to see. You don't want a groove that is tight, you cannot see. You want a wide groove, so when you see easily, you can go deeper and deeper without fear of piercing the posterior capsule. And the bevel down, because this decreases the propagation of the ultrasound energy to the cornea endothelium, so you protect it and you are working in the capsular bag. Second, you can put the chopper in front of the tip, so it again absorbs part of the energy. Then once you reach the depth that you want, and you see you have a wide groove, then you turn the bevel to the normal position, bevel up, and you work as if it is a normal case. And if it is very hard, you are going to use the tip as a driller, and you drill the shell, the whole shell. You go drilling into the nucleus and rotate. Two important things that you should know. One is you should, in any hard cataract, you have to have a good exposure of the tip. If you don't have a good exposure of the tip, then you will not embed enough. It will make it difficult for you to do the hole drilling, and it will make it difficult for you to hold the nucleus properly, to chop it into smaller and smaller pieces. The second important thing, that whenever you don't see the red reflex, never, in my opinion, do hydrosection. For two reasons in hard cataract, hydrosection is not an option for me at all. Number one, because at the beginning of the surgery, I want the lens to be fixed. Number two, during your work doing this shaving part, automatically the nucleus will be hydrosected when you need it to rotate. Third, if you don't see through a red reflex and you do hydrosection, you have a high risk of capsular block syndrome. So for these 3 points, I never do hard dissection if I don't see well. This is an example of the most extreme case, a kyphotic patient that they have to work standing. This is the only position the patient can be positioned. But having a technique in your mind, and you can do it routinely, even in this case, I have to work standing. So I'm using one foot only, and I cannot change the microscope. This is the true black cataract. Even the stain really does not give you a great edge. So, and you tend to make it towards the larger side because you'll have a lot of manipulation. Sometimes these lenses are subluxated. So as you can see, I'm doing the rexes. I don't do hydrosection. I expose the tip. The bevel is down, and then I shave the upper part of the nucleus. The aim is to convert a thick lens into a normal thickness lens, and second aim is to create for me a cavity and a well that I can see through it to go deeper. Once I shave like this, I noticed that I did not complete the rexes because of the bad visualization. So I stopped, completed the rexes, because a continuous capsulorhexis in such cases is extremely important. As you can see, this is the hole drilling technique, and you can see the rotation of the nucleus is very easy because it is hydrosected through the fluid. And you can see I'm working standing, and the pupil is getting closer. But using the vertical chop with this technique, you can see, you can trace where is the part of the nucleus that is preventing you from cracking. Whenever you will see it coming, what they call gummy nucleus, just focus down, shave it, or follow the cracks with the chopper. This is a Neumann nucleus splitter. And the idea always in hard cataracts, you protect the endothelium with viscoelastic, but also it is not how long you do use the ultrasound, it is where you are using the ultrasound. And if you notice, I'm trying always to be behind the iris in the capsular bag, and even if at one point I get in the anterior chamber, I try to protect the cornea by embedding into the nucleus. There is no propagation. And you can judge always in such cases, even if it takes longer time than usual, you can judge your post-operative corneal appearance by seeing that the cornea is going clear all through. And also you can almost always judge your effect on the corneal endothelium. If you're using methylcellulose or viscoadhesive, there are entrapped fine air bubbles that are entrapped in the back of the cornea, and if you see them not moving so much, then you are safe on the cornea. And you can see also the wound there is no wound burn, and this is due to the proper interruption of the ultrasound. And in spite of the fact that this is a very hard nucleus, still you can carefully deal with it as if it is a little bit difficult but not impossible nucleus. Protecting the two most feared things is the corneal endothelium and the posterior capsule. So the same concept can be applied even in intumescent cataract, because intumescent cataract can be white and not hard, but it can be also brown or black. So once you overcome the problem of the capsulorhexis, again, the two nuclei concept can be easily applied and repeatable. The best thing in any type of surgery is to be able to repeat the same technique in each case with improvement. And even if you have problems, you will understand where did you do something wrong, so you'll not repeat it again. Don't leave things for luck or يعني حد نحس معدي. Always have a technique that is repeatable. And to have a repeatable technique in difficult cases, you have to have a concept and then a strategy, and you know what you are really tackling and facing. Exactly the same way. So even this is the last thing, just even with a narrow pupil like this, having the concept, you can do properly the same technique. Usually it doesn't, you don't have to use, I don't use retractors for the pupil, but everybody will do whatever he likes to do. But again, I'm showing this case because the concept is that I can shave what I see and then create the crater, so I can go very deep and get the result exactly what I want, saving the cornea and saving the posterior capsule. And in any hard cataract, you have to think it is phacoaspiration, not phacoemulsification. Your main player is the vacuum, and you are only tackling using the ultrasound to help you aspirate properly. Okay, so thank you for your attention, and we can discuss questions. I think we have time for discussion, right?
Yeah, we will have time for discussion, but Dr. Pranendra, no, just...
You said he's not here.
He had... No, just let's finish it then, because we need to see all the... Yes.
I'm sorry, yeah, because...
Till he come, we are going to ask Dr. Yahya. Yes. When you...
More time for discussion.
لا موجود. Yes. When you have holes inside the nucleus, you crack the nucleus through the holes?
No, you engage alongside the hole.
Okay.
And crack through the hole. You don't engage into the hole, you engage with the probe. This is your hand fixing the lens.
The wall of the hole.
And the weakest part is the hole.
Shall I? Yeah. Thank you. I think it's a wonderful session which is going on, and most of the things have been made easy by my previous speakers. So management of PCR during phacoemulsification, especially in hard cataracts. I am Purendra Basin. So I have no financial interest. Coming to the PCR, what are the early signs or development of zonal dialysis? There occurs sudden deepening of the anterior chamber with momentary pupil dilatation. That is one important thing, and usually we miss it, and we keep on continuing our procedure, phacoemulsification. There could be sudden transitory appearance of a clear red reflex through the cataract, or apparent inability to rotate a previously mobile nucleus. This is because of the presence of the vitreous. And there is reduced efficiency of nucleus sculpting and holding. Again, this is because of the presence of the vitreous in front of the phaco tip. Sudden difficulty in burying the phaco needle into nucleus. Tipping of one pole of the nucleus. If you have missed all these things, you will find that the nucleus has started tipping into the vitreous cavity. And secondly, when it is the fluid vitreous is there, and the senile or very elderly patients. And descent of the nucleus into the anterior vitreous. These are the things which should be looked upon. Now, this is my first case, and we are doing phacoemulsification. This is a fairly hard cataract. I'm doing a direct chop here, and most of the times when you face the PC rent when you are sculpting or removing the last quadrant. Now I have deliberately made it the speed of this made slow, just to show that because of the post-occlusion surge, there is sudden shallowing of the anterior chamber, there is sudden upthrust of the posterior capsule, there has developed a PC rent, small rent over there. And um, I have missed pushing the viscoelastic with my phaco tip inside, and which should not be done. Now what I do is, I fill the chamber with viscoelastic. I'm putting a 3-piece lens in the sulcus, and that will act like a scaffold. And this is the rent which no, I'm sorry. Can I go to the previous one? Can you start again? Yeah. Yes, yes. Can you please run it? Okay, now in this case, we are doing phacoemulsification is being done, everything is going smoothly, but there has appeared a rent inside. And again, this has appeared during the time when the last piece of the nucleus was being taken out. Now what we do is, we fill the chamber with viscoelastic, remove the phaco needle, and with the help of a retractor, remove the soft nucleus, soft cortex, aspirate it, and this is with the help of phaco cutter. So this will cut the vitreous along with the removal of the cortex, and this is at the irrigation aspiration mode and cut mode. And then after removing the cortex, you can see very well there is a rent here, and placed a lens in the sulcus. So this is again a dense cataract. There is a presence of vitreous there, where there has appeared a rent. We have filled the chamber. Again, to show it, emphasize the help of taking the help of vitreous cutter, we are removing the epinucleus and the soft cortex. There is a rent. Fill the chamber with viscoelastic, place a 3-piece lens in the sulcus. This is guided by the Lister hook. So, mind it, when you place the power of the lens, you decrease the power by half a diopter so that it should not create a myopia. So, sometimes in the traumatic cases, you get a pre-existing rent. So in this particular case, there was a pre-existing rent, and which one can see here. So after removing the cortex, and the margins are also slightly fibrosed, fill the chamber with viscoelastic, do anterior vitrectomy to remove all the cortex part and the presence of the vitreous there, and try to convert it into a posterior capsular axis. These margins can be converted into a posterior capsular axis. This is very important to ensure that it doesn't enlarge further when you are placing the lens in the bag. And with the micro instruments, it becomes easy for all of us. And dispersive viscoelastic will maintain the chamber and plug the vitreous also. So after the vitrectomy, this lens is placed in the bag, and you can see the capsular axis and posterior opening in the. So this is a last case which I will be showing here. Capsular axis, hydrodissection, then making the nucleus free, as we do it on all our cases. And can you make it further near the end, or let it be? Phacoemulsification is being done. Oh. So to summarize, we should avoid sudden withdrawal of phaco or IA handpiece from the eye. Sudden anterior chamber collapse can cause enlargement of the PC rent and increase in the, and we develop a vitreous prolapse in the anterior chamber. Ideal is that the surgeon should stay put with the irrigating running. Fill the anterior chamber with OVD through the side port incision before removing the phaco, and to prevent the enlargement of the rent to block vitreous prolapse. A low viscosity, less cohesive, and highly dispersive OVD is an ideal one to be used. And however, if it is not available at hand, then any OVD will work, and this will to maintain the cases. And when the PCR occurs, continue with phacoemulsification if the nucleus is soft and only a small residual amount is present. And plug the, try to, that the vitreous should not prolapse further. Plug the area of PCR and chamber with a dispersive OVD. A slow motion phaco, reduce the aspiration flow rate, decrease the vacuum, lower the infusion bottle height to prevent pressurizing the anterior chamber and hydration of the vitreous and driving the nucleus into the vitreous cavity. Use multi-piece hydrophobic acrylic IOL as a scaffold to prevent PCR extension and to complete phacoemulsification and the removal of the cortex. Removal of residual cortex and epinucleus, it's better to use a bimanual technique. One can use vitreous cutter at an IA cut mode. The cortex removed from the tear should be removed initially and should be stripped towards the rent, toward the area of the rent. This manual technique of dry aspiration of cortex decreases the risk of tear extension and vitreous loss. The goal is to remove the remaining lens matter without causing vitreoretinal traction and without extending the PCR further, while at the same time minimizing the further vitreous loss. Thank you.
Thank you very much for excellent presentation. We can discuss now about, yeah, you have one on the points in your summary, you said when you have a posterior capsule opening and it's a soft nucleus, continue phacoemulsification.
Yeah.
So this is your point of view in such case.
Yeah, the thing is that you have to look, if your phaco piece is engaged at the phaco tip and you have visualized the rent is there. So, and you complete that phaco, that piece of phaco which is engaged at the phaco tip, and then you push the viscoelastic.
Yes,
till the time.
This is just so as not to avoid confusion for that. But yes,
Otherwise,
it's very important.
Very important.
Because if you continue, he clarified that it is engaged already, the part. But otherwise, you can induce vitreous loss or more vitreous loss.
Yes.
And this is the question you should ask yourself when you identify there is posterior capsule rupture, that you should ask, is there vitreous or no vitreous, and you will manage accordingly. But this is
when you see the PC rent, you should not get panic. You should be very cool, calm, and composed, and you see where you are, and stay there itself. That's what my other thing was. And then you, if you are able to complete that phacoemulsification of that piece which is engaged at the tip, you continue with it. But immediately stop and push the viscoelastic from the second hand.
This is very important.
Yeah, this is the way we should go ahead. Yes.
Dr. Prenda, wonderful presentation. Congratulations for this presentation.
Thank
If you are going to do an anterior vitrectomy, are you go for anterior vitrectomy or pars plana vitrectomy? Anterior vitrectomy or pars plana vitrectomy?
No, pars plana vitrectomy has been described by Dr. Amar Vasavda to go through the pars plana route. But what I feel is we are not well versed with that. And if we do it with the anterior approach, that also works in the same way. And like I have shown in a couple of my cases, that I do anterior vitrectomy through the paracentesis wound. And it should be bimanual.
I agree, because recently more people are talking that you should go through the pars plicata or pars plana vitrectomy. The idea is the objection on the anterior, which was done for so many years, is that you are pulling more vitreous. The trick that has always been, if you know, if you learn it in the proper way, that if you do limbal vitrectomy, the first thing, because it's an opening and there is vitreous knuckle, for example, the trick is you dip into the vitreous behind this knuckle and then do vitrectomy, very high cutting rate and low vacuum. Then you'll create a space that will pull down the vitreous in front of it. If you start doing the vitrectomy through the bulging part first, then you are pulling more vitreous. And this is risky, and that's why then pars plana is good. But remember that pars plana, like you are stated, is not every surgeon is not comfortable with. And at the same time, it has its own inherent complications.
Yes.
I mean, even the sclerotomy.
Dr. Yahya, I do agree with you fully, but when the surgeon not facing these problems frequently, and the first things Dr. Parendra said that the first things when he's seeing or she's seeing the vitreous tag, they will go out and they will ask for. So here, this step going out,
yeah,
we will create a lot of damage. The whole vitreous coming up, and the small rent will be
enlarged.
So here, in that site, we have the vitreous in. If we will go anteriorly, the vitreous, as we know all, it will go through and to the sulcus, to the bag, to the sulcus, and to the anterior chamber. So whatever anteriorly we are doing, that's right, Dr. Yahya is the expert person, the most expert person here. But imagine me as a poor guy, going in, and I need to fast because the vitreous, I'm seeing it coming from the incision side because my incision was not good. And the hard cataract, there was a burning at the site of the incision. The incision start to be oval shape, open. All the vitreous is coming to you. If you will go anteriorly, by anterior vitreous, even if you duck down, the vitreous will not return back. So you will do your best. Now if doing posteriorly, sometimes I'm going anterior just to clean the rent of the vitreous that they're stuck or incarcerated in the incision. David Chang having a beautiful study on that, comparing between anterior and posterior vitreous in a small tag in the posterior, how he's saving that circular or whatever the shape and changing it by doing a posterior vitreous. And he presented a lot. If you will go to posteriorly and draw the vitreous from all the sides, then you can maintain even the shape of this rupture.
The rupture.
So that's the issue.
Can I say something?
I can show you tens of cases from keeping the shape. But the idea is both are correct. Yes. But if you have to do through the anterior, you should know the right way to avoid what Dr. Safwan is saying. And the trick is, if you're doing if you go through the vitreous prolapsing and then you go and start cutting, it is not aimed essentially to remove you cannot remove the vitreous in the wound in this way. But the idea is to cut the connection between the vitreous that prolapse with the remaining vitreous, so you will not pull on the retina. And the main pulling will occur at the vitreous base where it is attached firmly, and this can induce retinal breaks that will later present with retinal detachment.
I agree fully. Can I add, can I say something? The thing is that, as you were saying, that if vitreous is in the section, in the phaco wound, it has come out. So what we will do is, in such a situation, first we will cut that vitreous. We will cut from there. Then we will go inside, and the vitreous, which is the knuckle of vitreous which is coming out, first we have cut it from outside, then we will cut from there itself. And it will be in a cut IA mode. First we will cut and then we will aspirate it. Then that should be the first thing in such a situation. Then with the IA cut mode, later on you can clean everything, use, that is how, means we have to remove, as has been rightly said by our senior colleague, that vitreous is a tissue which is connected to the base of the base and to the optic disc and to the macula.
I have a question to Dr. Yahya. If you have a hard nucleus and suddenly you have a drop nucleus, from your experience, Dr. Yahya, what the steps for everyone to do to save the eye?
So at what stage?
The
Of the
nucleus
fake-
nearly
Yeah, most of the nucleus
yeah, the
is
whole
there,
nucleus,
and
yes.
it's open. You will you have two situations: either the nucleus is in the anterior vitreous and you see it, or it dropped completely. Usually, this will happen only if you have a fluid vitreous. But usually in like 60s, even 70s, the patient, they have formed vitreous, and the nucleus will not fall into the retina. If it is in the anterior vitreous, if you know the maneuver, the easiest way is to do what's called PAL technique, posterior assisted levitation. So you form the anterior chamber with viscoelastic so as not to collapse, and with an MVR, you just go into the pars plana and elevate the nucleus. So you hold it from falling back. Then you have to widen the wound wide enough to be able, with a victus, to deliver the nucleus. A victus, not pressure. So do you agree, or this is okay? If it fall down, I will clean up the vitreous, and would refer, and even I can implant and then refer to Dr. Ayman Madinat to do vitrectomy.
So the most important that if the nucleus dropped totally down, I don't panic. I do anterior vitrectomy. I remove all the cortex. I leave the eye quiet for the posterior segment to continue. This is the
I
most
think
important.
in both the situation,
I do agree. I do agree with you. You need to clean the vitreous. You need to leave the eye quiet, because most of the eyes that, like the eye that yesterday I did the fourth lunge with it, it was not quiet. The vitreous incarcerated in, the iris incarcerated in the main wound. The wound is being enlarged and enlarged in different levels. See, because the nucleus is dropped down.
as long as vitreous is there touching the cornea, cornea is not
Yeah.
going to become clear. It is not going to get clear, and if it is not clear, the VR surgeon will not be able to
Yeah.
perform
I
the
think
VR surgery.
just we need to do a simple survey here and asking our audience, how many of our colleagues used a vitrectomy or cutter while in any accident having? How many using the cutter? No, you are most expert, sir. I'm not. The question is not for you. No, for the audience that they are anterior segment and they are doing cataract. No, sir. It's not this
Not
way.
this.
I'm talking about the simple anterior vitrectomy. I'm not talking about the vitrectomy. I'm talking how many audience doing anterior segment surgery touch the cutter, know how the cutter work. See? So among all of us, we need to know how's the cutter work. How's the cutter being on a mood of cut and IA or an IA and cut? Because this is a basic ABC. So when we have a vitreous in the AC, we can manage this concept, because here the simple issues doesn't need Professor Ayman Dena to call him and do this anterior vitrectomy. So it's a simple issue. And knowing the, sorry.
No, it's a very good point, but just I want to add, you should know also what is the cutting rate and what is the
Yeah.
aspiration and what probe you are using. You can
Exactly.
have
Should not be
20
afraid
gauge,
of using cutter.
you can have
Yes.
20 gauge,
It's like a
vitrectomy,
bimanual
or
irrigation
23 or 25. And as a rule, you need to have very high cutting rate, correct me if I'm wrong,
Yeah.
to avoid pulling on the vitreous, and low vacuum, but the vacuum will change according to the gauge of the vitrector. So this is
Yeah.
very important to know.
Triamcinolone and M. Yeah.
Triamcinolone
Okay,
use
this
is very, very
this is
important.
another point we can discuss. This is controversial. So for you, let's ask the panel.
Sir.
Do you,
I don't
if you have
use-
vitreous loss, do you prefer to use Kinacort or not, Ashraf? And
I don't-
Dr.
I
Safwan
don't-
and
I don't use the Kinacort.
Kinacort.
Kenacort is required not in all cases. That is what, not in all cases, but once you are not sure of that the vitreous is totally removed, then you try to stain with Kenacort.
So you are using Kinacort in whatever situations you think you need to.
Yeah.
Ashraf and I were not using Kinacort alone. So for the audience, we want to listen to your why you use it.
Yes.
And for us, we are going to tell you why we don't use it and how we get a good result.
So see, when you are feeling that you finished and you are very happy, the lens is in, and whether it's captured anterior or upward capturing, whatever you are doing, and you feel that nothing is there, the pupil is round and everything's quiet, and there's no leak from the incisions.
bone.
And then once you are injecting the triamcinolone, you'll see the strand coming upward through the incisions and going out.
Correct. That is
That's the issue that I don't like.
Okay,
No.
we
that's-
counterpoint.
For sure. Yeah.
But
For
that
me-
is what has to
But
be
I
looked
will
at.
tell. I will just
That is
tell-
what has to be looked at.
The kinecort is a good thing. Of course, you see the vitreous well, but if you have an opening of the posterior vitreous, you can have an opening at any time of the surgery. In the midway, at the end, during irrigation aspiration. Usually, if you inject, you will see the vitreous, but we spoil all visualization. It will be particles on the iris. You don't see the posterior capsule well. Everything will be disturbed. On the other hand, if you don't use the kinecort and you are trained to work in a high magnification, you will see every bit of vitreous. And to avoid the trick that Dr. Safwan correctly mentioned, sometimes you can have a pupil rounded, but there is a strand, and this is why you should learn the proper technique to detect if there is vitreous or not, which is going from a paracentesis and in different parts and sweeping from the periphery to the center. I assure you, 100% of the time, you will see this trend and you will cut it. And one of the signs also is if you never depend on indirect signs. Always see what you are doing.
I think we
with all
need to
the
complete the vitrectomy. I mean, when you are doing vitrectomy, like we have to follow even the last strand of it, and we should do it. We should not come out early while doing the anterior vitrectomy. That is what is important. And on the surface of the iris, you sweep with the cutter up.
عشان
you
كده
sweep
air
it
is
and see.
deceiving.
Yeah.
Having a full
One
air
bubble.
bubble like classic teaching is completely deceiving. يعني.
Yeah, in my way I'm doing the vitreous, I don't stain with triamcinolone. We have three tricks. Elevate all the new microscopes. All the new microscopes, when you elevate the magnification, the depth of focus is very high,
good,
and you can see, as Dr. Yahya, all the details of the vitreous. It's very clear. As you can see the OVD, you can see the all OVD during removal from inside the bag. The same OVD like the vitreous. Then after you finish everything, once you close the pupil, so you have the iris tissue in a maximum stretch.
Yeah.
So any sweep inside the anterior chamber, the iris is floppy because it's completely constricted. So any touch of the vitreous strand to the iris, not when it is dilated. When it's dilated, there is no trampoline of the iris. Once closed pupil, so the tissue of the iris will be maximum, and it's like trampoline.
But if you close it, then it will be more difficult to implant the lens if you close it with myotic.
I mean, after I finish.
Ah, at the
before
end, okay.
Yeah, at the end. So when I close the pupil,
But it's
yeah,
cool. And probably this will be the last
Just for
comment
our,
because
for
we
our
are.
colleagues who would like to use triamcinolone if there is a vitreous loss, don't put the full concentration of triamcinolone. You will, as Professor Yahya said, you will lose all visualization. Diluted 1 to 4, you still have a good staining of the vitreous, and you will have a good visualization. So just dilute it.
I think I agree with you. We use 0.25 in 1 cc of this thing. Say 1 cc syringe and 0.25 ml of triamcinolone, and then 0.75 of the, yeah.
I agree with Dr. Madanat. However, in a complex and complicated cataract surgery, after trying to do everything, and by the end, there is a fall piece and prolapse of the vitreous. By this time, the cornea most probably is cloudy. This is the advantage of kinecort. At that time, whatever, if you are going to increase the magnification, still the cornea is cloudy. So it's a blessed using kinecort. It's, you can see the strands. You can dilute
So
it. You do not
it's a
inject.
valid-
You
it's a
cannot.
valid point.
Also, using my call by the end of the surgery, so the iris closes. You can detect any strands in
It's
the
a
vitreous.
valid point in case you have a bad visualization.
Thank you.
But as a routine, no.
Well, it's a valid.
I think we have to conclude. We are on time. طبعا بس هو اوريدي احنا كنا قايلين يعني ما خفناش منه يعني.
It's a valid for obsessive.
Thank you very much for your attendance and كل سنة وانتم طيبين بقى. خلاص.
I really thank you.
لا مش انا اللي انت اللي الهيومر انت. لا الهيومر الدكتور.
الهيومر يا جدع انجز الموضوع ده.
So, we'll end this very successful conference with a smile. With a smile. This is the idea of our Professor Majdi Musa and also Dr. Muhammad Al-Omari. And we need everybody to leave with a smile. Huh? And Dr. Nadeem. We need. He's smiling.
He's always smiling.
Slight change in the program. We will start by Dr. Muhammad Awadallah because he had a funny video, and then we will talk as funny situations happen to us during whatever, seeing patients, doing surgery, getting to sleep after a long day. So we'll start by Dr. Muhammad Awadallah.
Yeah. So basically, this is an incident that happened long ago in one of my vitrectomies. I needed to use the Tano scraper, which is the diamond dust tip, and we'll see the video here. So basically, everything is going nice. Rhegmatogenous detachment is the tear. Putting BFCL and doing shaving of the vase. I'm happy. Then I needed to use the Tano scraper. I entered. There is the tip. There is no tip. There is no tip. Where's the tip? Tano has no tip. So I started to see what's happening, and now where the tip has gone? Now it has fallen inside the eye while I'm entering. So I started to chase this tip to get it out. So it's a 23 gauge vitrectomy. The tip was 25. I thought I can catch it with the Ocutome. I catch it now, fall again. I'm starting to get pissed off. Maybe I use another method, getting with the forceps. We'll get it now, trying to get out with this. It has fall again. So angry and upset. finally, yes, I got it, I got it out. Thank you.
Let me go up and give you a couple of funny things happened to me. Don't take photograph. Take me while I'm
You
going
know
down.
why? You know why you couldn't pick up that tip? No, no, you said
The purpose
not
of this
tip.
is to make you laugh at the end of the day because we have 3 long days. Everybody was escaping to dinner, to lunch, going around, escaping from Muhammad Al-Amri because he's chasing everybody in the hall, even me. So nobody can, you know, the closing of any session, once you find Dr. Al-Amri coming in, it's mean the closure of the session. Nobody can break that. So he's good at that. He's good at that. But I will tell you a couple of funny situations. I know some of you doesn't speak Arabic, though it will be much better in Arabic, but anyhow, I'll try to translate it. I have a very old, rich guy coming to my clinic and ask me, I can't see while I'm driving. I drive at night, I don't see anything. It's a simple way. I told him, you are a myope, you need a glasses. And I did the prescription, can you see well? He said, very well, 6/6. So he was happy. And then when I gave him a prescription, I said, this is your prescription. He said, what is this? I need to see without the glasses. That was almost 30 years ago. So there was no LASIK, there was nothing. I told him, what can I do for you? He said, you can do a lot of things. I am wealthy, I have a lot of money. I said, it is not about money. What can I do for you to see? He said, I have a good idea, but I need your help. Make this prescription, I need to drive. This is the only thing he couldn't do. Make this prescription to the company I'm buying the car from. I said, why? He said, because they will make the front shield with the same power so I can drive at night. I said, how come? He said, this is my idea. You have to fulfill it. I'm here paying you to fulfill my requirement. Do that and I will be happy. I'm rich. They will do whatever I do. I said, how come to make the front shield? He said, it will work, but just from you, you give a prescription, my power, they will do it at the front shield. So I was so funny. I think, go with him. So I said, when you are going reverse, what are you going to do? You will not see back there. He said, I can do the back one. You see, I mean, I'm trying to make funny. He doesn't make sense. I mean, it doesn't make sense. He's not funny. He was speaking seriously. He needed a solution. And at the end, I have many patients waiting outside. So some of them are knocking, what's going on in there? I said, we are driving at night. So the guy was so funny. This is one of the funniest things happened to me. And I couldn't convince him this is impossible. And he went to the glasses shop near to the hospital I'm working in. And he was asking them to give him glasses to put it on. And to order glasses for him from outside, from abroad, to put it on the front shield. So, yes, he's thinking outside the box, inside the car. Outside the box, inside the car. That's what he needs. He needs to drive. He doesn't need to see anything else. Second situation was a funny thing, but if it happens, it will be a disaster. My name is Magdi Musa, and I work in a hospital where other doctor of ENT called Magdi Isa. And you all know Isa and Musa are prophets. So they never called the prophets, they called Magdi. So people are standing in the ward to be calling. So they called, who is Dr. Magdi's patient? The patient came in. So he came in, he went to the operating room, and the anesthesia doctor said, open your mouth. I said, why I open my mouth? I said, please open your mouth. He said, I'm not opening my mouth. He said, you are going to do operation. We need to see before intubation how the tonsils are large. He said, why the tonsils are large? Because you are going to do tonsillectomy. He said, no, I'm not going to do tonsillectomy. I'm going to do cataract. So they picked up the wrong guy to do tonsillectomy for him instead of my case of cataract. And they never told me that except 5 years later. The doctor was sitting with me in a conference. He told me, we picked up one of your patients 5 years ago and we were going to do tonsillectomy. And the patient was crying at us and he almost hit us because we were going to give him general anesthesia. And I was doing cataract by local anesthesia. So the guy went crazy. But imagine if this patient was done tonsillectomy and I got the other guy who's tonsillectomy to do cataract for him. That would be a disaster. Would it be? That would be a disaster. So I never forget this, but I've never knew about that. And he told me after that, if you remember, we used to do like bracelet with the patient name, and after that, we used to do something for the patient who's doing cataract because they are sitting together. There is a mark here, there is a name here, and whatever they call, they have to read the name in there. So this is a big mistake. If it happened, it will be like a disaster, but it was, I mean, thanks God, but I've never knew about that. So always check your patient. If they have tonsillitis, check with them. If they have cataract, check them then. Thank you so much for this. Who's next? Dr. Ayman Madanet. Yes. Yes. Yes.
To talk about funny situations. Good afternoon. The first funny situation in the early 90s, I was a junior consultant and I was happy to have my own list. And we used to have the ophthalmic surgery in the main surgical theater. And near to me, there was the theater for the pediatric surgery. I had a 1-year-old baby for probing. And my colleague, he had the same age baby for urethral dilatation. My baby was crying too much. And the pediatric surgeon was so passionate, you know. He went in, Habibi, don't cry, please. And he held him, and he took him to the theater. Instead of doing probing, they did urethral dilatation for him. And he came out to the family, he said, oh, congratulations, the surgery was great. They told him, what surgery? Said, the urethral surgery. Said, no, we came for a nice surgery. Come on, what have you done, you know? We need grandchildren, this is going to be married, you know? This time, I heard the noise, I went out, I said, don't worry about the dynasty, he will even be better having children later on with the new procedure. And we had to book him after 1 week for the probing. This was one of the funniest situations. The other funny situation happened in the early 80s. I was a resident, senior resident, and I was sent to the peripheral hospital to cover for one of the specialists who went to do Hajj. At noon, here came an old man. At that time, we were doing intracap. Intracap, for people who don't know, we used to dilate the pupil, insert a cryo, pray for the vitreous not to follow the lens, remove the lens, and close. And we used to give +10. This man had a hand movement in one eye and counting fingers in the other. So I admit him for surgery. I had rest the second day. This guy had hypertension, heart failure, his kidneys were not working properly. So I wrote a consultation for my medical colleague. And I saw him at lunch. I told him, Dr. Muhammad, please, I have this old guy. Please take care of him. He is not seeing anything. We need to do surgery. At that time, we used to do surgery. We used to admit patients for like few days and do the surgery under general anesthesia. The second day, the anesthetist was so furious. Dr. Madanat, I said, yes, sir. Said, and he was a colonel. I was a lieutenant at the time. Yes, sir. Said, did you write a consultation for this patient? I said, yes. Said, please, can you read this consultation? I'll say it in Arabic. My colleague wrote, فإما حياة فيها يرى وإما يوارى تحت الثرى. محمد ذي بعبابنا. Honest. He said, either you treat him and he will see, or he will die. And the anesthetist was so furious. What yara ma yara? I did something. And I called my colleague. I told him, please, what have you done? He said, do you think I am a prophet? You brought me a patient, heart failure, kidney failure, liver failure. Am I Jesus Christ? I'm going to make him fit in 24 hours? Either you do the surgery or whatever, do whatever you want. Very funny situation, but very, very difficult situation. At that time, we did a short anesthesia, 10 minutes. We removed the nucleus. We used to give him plus 10, and the gentleman said, thank you. I said, don't tell me thank you. Say thank you to Dr. Mohammed Ababne, who recommended the surgery for you. Thank you very much.
Muhammad Tawfiq.
دكتور محمد توفيق موجود؟ You have a talk after that? No? He was the last one? Okay, let's implement. Let's ask the audience if anybody had a very funny situation, so he can come up and say, even in Arabic, if he doesn't want to translate that. And I'm ready to translate if he doesn't, but not only in Arabic, not Indian, not other language. Only in Arabic, please. Don't laugh. You're Indian. You can translate that. Everybody's hungry? Everybody's hungry? فين العمري؟ تعال قول لنا funny situation من عندك. تعال هو أنت ما بتجيش غير في الكونكلوجن؟ تعال. تعال. لا ما عندكش حاجة إزاي؟ ده أنت عندك بلاوي.
I have a lot of situation with Dr. Majdi, but I will keep him for the next year, inshallah, not this year. So thank you very much. I'd like to thank you all. We apologize for any inconveniences happened. There is some delays, something happened here and here, and we hope to see you, inshallah, next year in the 5th Miyom. And now we can enjoy the last dinner for the conference, not the last dinner of the life. Thank you, and good night.
Yes, but let's thank this guy because he did a very great job. So can we have a big applause for this guy? He did a very great job. Thank you, Dr. Muhammad, because without you, nothing can happen. Without you, there will be no conclusion for any session. Thank you so much.
On the stage, it's
No, we can.
on the stage.
Why not every people
All the
staying
people
and then
here.
we give this way so you have the audience behind us?
Sure, sir.
How about that?